Hi, everyone. Thank you for joining tonight. We are so excited to talk about aging, memory, and elder care in South Asians. This is the fourth and final installment of our Women's Health series, which I'm so proud of. And we'll be talking a little bit about just the roadmap of everything we've covered so far and ending with this really important topic that impacts not just women, but everyone in the South Asian community. In order to say, make sure that we end on time, I will just get started. If you're not familiar with SAAPRI, a quick overview of who we are. So SAAPRI stands for the South Asian American Policy and Research Institute. We're a nonprofit, nonpartisan research organization established in 2001, and our mission is really to produce data-driven and human-centered research, as well as strengthen community advocacy for South Asian American communities. The work that we do includes a lot of different areas, but we have projects that look at civic engagement, economic development, and I work in healthcare as the Health Equity Research Fellow. And our goal is really just to advance public policy and produce data-driven objectives that are based on community-centered initiatives. So SAAPRI is part of this greater coalition called the AHC, or the Asian Health Coalition. The AHC is a collaborative network of organizations that's committed to advancing health equity and improving health outcomes for minority populations. As part of our role in this coalition, we promote the All of Us research program, which aims to gather comprehensive health data from diverse communities so we can better inform precision medicine and tailored healthcare solutions, especially for South Asian Americans. If you are interested in learning more about the All of Us program, feel free to follow that link to the NIH's website or the link below to learn more about the AHC, or feel free to message in the chat or reach out to SAAPRI, and we're happy to get you connected. And then the last piece to cover just before we get started is a disclaimer. The information provided during this event is for general informational and educational purposes only. We do not provide medical advice, diagnosis, or treatment information, and any views expressed by the speakers, panelists, or participants are their own and do not necessarily reflect the views of SAAPRI. So just wanted to get all of that out of the way before we get our lovely speakers to introduce themselves. With that, I wanted to introduce our speakers, Dr. Arunima Sarkar and Monisha Jain, and give them each just a little bit of time to tell us a bit about themselves and what they do, as well as, why they're so passionate about the elderly and South Asian Americans. We're just going to start with the left. So Dr. Sarkar, if you want to go first.
Hi, thank you everyone for inviting me. This looks a nice area to talk about elderly. Well, I'm a geriatrician, so that's what I do and that's what I love. All of my patients are obviously elders, definitely over 65. So I am actually a primary care physician for most of my patients. Sometimes we do the consultative service. And I also work as a hospice medical director, so very actively involved in patients' goals of care discussion, their advanced directive planning, advanced care planning, and all those things. Plus, on the other side, I am also involved in education of our geriatric fellows here. So yes, as a clinician, as an educator, and that's what I am. And being a geriatrician, that's why I love to work with my patients, and I'm very passionate about it. So yeah, that's who I am.
Monisha, feel free to tell us a little bit about yourself.
Sure. Hi, everyone. My name is Monisha Jain, and I'm a physical therapist and a dementia specialist and a geriatric care consultant for Person-Centered Senior Solutions. So as geriatric care managers, we basically help families figure out next steps for their aging loved ones. We're almost like the air traffic control of the whole healthcare system. So we jump in during a crisis situation where maybe someone is having a unexpected discharge from the hospital or a rehab facility, and knowing all the clinical knowledge that we have, we can jump in and we know all the therapy rules with Medicare. We can advocate for our clients and determine is it truly a safe discharge or not, or we can advocate and request for an extension. If it's not a crisis situation, many times we get calls from kids telling us that they're worried because mom or dad keeps falling at home, or they've noticed cognitive changes and they're not sure, what's going on. So again, being a therapist myself, we have the ability to go to someone's house, do a home safety assessment, determine, how they're doing physically and cognitively, and figure out, does this person need a certain helper at home? And we can determine how many hours of help that could be. Or if someone is really not safe to be at home, we can guide families in terms of what those options could be based on their financial resources. Like Dr. Sarkar, also, we believe a lot in proactive planning. So we also help make sure, kids have had those end of life discussions with their loved ones. We want to make sure that, powers of attorney are set up. So God forbid, if there is a crisis, nobody is scrambling last minute. And now with the beauty of Zoom, we have the ability to see people all over the US and even sometimes internationally. So it's definitely very rewarding, and I'm passionate about, helping seniors and just guiding families because, as you know, this whole healthcare system can be so daunting.
Yeah, we are so grateful to have both of your perspectives today because, kind of that interdisciplinary work is so key to taking good care of the elderly population, especially with all of their needs. You have all maybe seen me before. My name is Prottusha Sarkar. I am the Health Equity Research Fellow here at SAAPRI. I will be graduating for medical school next week on Monday, so I will be Dr. Sarkar in a couple of days. I'm also graduating with my MBA, and I'm passionate about disparities and taking good care of the South Asian population because we deserve the same quality care as anyone else does. And sometimes that requires a little bit of extra thought and a little bit of extra cultural context. And that's what, we try to do here at SAAPRI and really help provide that for everyone. So with that, I'll get started. So like I said, I just wanted to do a quick run through of the Women's Health series for those of you who have attended previous webinars or have not. This was the brainchild of me and the rest of the health equity team earlier on in the year. We really wanted to cover different points in women's lives and kind of centering it around really important discussions that concern, people's health at different ages and at different maybe social points in their lives or career points in their lives. In August 2024, we did the first installment, which was safe sex, contraception, and healthy relationships, really targeted at maybe a younger population who might be thinking about those things or thinking about starting a family or having children. Then we talked about cardiometabolic health in February 2025 with two wonderful physicians who are part of the Masala study, which I always plug. You should definitely go check it out if you haven't already checked it out. Because we know that South Asians are just higher risk for cardiovascular disease. And there's a lot of important research that's come out in the Masala study that has helped us see things that we can, do to improve that. The third installment was just last month. It was on menopause and sexual health. We had Dr. Aman and a pelvic floor physical therapist come and speak to us about the importance of the pelvic floor and what the menopause transition is like, as well as what that can feel like for a lot of South Asians who are going through menopause and how unspoken it is, and it's very much buried in a lot of taboos and stigmas. But it's important to talk about because that's a big change in how a lot of older women feel. May 2025, which is today, we're going to be talking about aging, memory, and elderly care with Dr. Sarkar and Monisha here. And then this summer, we hope to come out with our Women's Health Summative Report, which will summarize all the things that we've discussed over the past year, as well as our recommendations for these topics and, ways that we can continue to improve the state of healthcare for women across their lives. So with that, I wanted to come to our first topic, which is just kind of talking about the importance of the elderly in South Asian culture. And I wanted to ask Monisha to kind of share her thoughts about this and, your experiences working in your own life or with people that you've worked with in your work.
Sure. So, I mean, clearly, the elderly population play an important role in our South Asian culture. We often view them as possessors of knowledge, history, and spirituality. And I think that, age hierarchy is strong. We tend to consider the older members of our family to be like the main decision makers. As we're well aware, in India, multi-generational families are so common, but it's becoming increasingly common in the US, where, as parents age, they tend to either move closer to their kids. Many of our college kids, they say, in fact, 59% of young college students, once they graduate, end up moving back home, especially because of rising costs, inflation. So more and more families are now seeming to be multi-generational. And many times parents also move closer because of childcare. I mean, me personally, I know my mom moved from Princeton to Chicago once my daughter was born, just to kind of help me out. So, we have definitely seen a shift with that, and it's becoming more common in the US too to have multi-generational families living together.
Yeah. Dr. Sarkar, is there anything you kind of wanted to add on that note?
I mean, this is something I do agree with this, that as I grew up with my grandparents, so I know how important they are in your life, that how they contribute. So it is really nice. And I think I do agree with Manisha on that we are getting more and more multi-generation family in here. And people are moving back and forth to be together. And this is something I see that I have a lot of my patients who have been living between Florida and here because of the weather. But now they are getting older, and the kids are saying, oh, you got to come close to me because I cannot always go to Florida to see you. And now they are all in the same place, in the same area. I think this is what the trend I am seeing, and it is good that with the multi-generational family. And it's very important that kids grow up with their grandparents and everybody is in that same place.
Yeah. So, as we think about all of those things, why the elderly are important, we also know, just objectively, they're a rising proportion of the population because people are living longer, and we're able to take better care of them as they get older. So, Dr. Sarkar, here, I wanted to ask you, as a geriatrician, what are some lifestyle considerations that start to change as you get older and once they start to think about what life will look like once you're 60, 65 plus?
So I see you have the 4M model. That's what we practice in our daily patient care. But one thing I want to bring up, that first of all, why this population is little different than the younger population is because of the physiology of aging. As patients are getting older, their whole body changes from head to toe. Every single system changes. So they need to change some life, in their lifestyle to remain active and be functional. Whether their functional ability to do things like exercise, right? Because there is change in the heart, change in the lungs. So their exercise ability is little less than what it used to be. But if they keep on doing their exercise, they can maintain their functional status. So taking some time off the daily schedule for yourself and keep moving. 30 minutes of your time, if you can spend for yourself, that's great. On the exercise, that's very important. Then I would say also, I will definitely say that what medication in 4Ms, one of them is a medication is there, right? So what medication someone was taking when they're young, they need to talk to their doctor about where they can take them now. because of whole body changes, how medicine is being metabolized in your body, you get rid of it, is different than when you were young. A very simple thing, usually we always tell patients that even over-the-counter medication has interaction, and whatever prescription medication you're taking, just discuss with your doctor. There can be interactions. You should not be taking them without discussing with your doctor. And mentation, I think we have a little more discussion, a little detailed discussion in the letter, that mentation, keeping yourself physically and mentally active is a crucial thing. As you're getting older, I know that a lot of people do retire as they're getting older, but that, like every morning when you wake up, you have something to do for the day, a schedule for the day. That is so, so important. And I see those who have those who has it actually do functionally much better than who do not. So keeping busy, volunteering some places, taking care of the grandkids, doing all the things that you love to do, that you enjoy as your hobby, I think keep that doing, because that helps with your mentation. And other one is a matters most. I think we have a little more detail in the letter, right? In the talk, when we talk about the what matters most, I think this one is more related to the advanced care planning, that what you want to do, what matters most to you, like being active, being functional, doing your things, and talking to the family what you value most. I think this is what is so important to have this discussion. I know um, I see a lot of South Asian families, and when I talk to them about advanced care planning, their answer to me is, "Oh, my son is going to take care of it." So I think that is where I start discussing this. Yes, the son will take care of it, but what's your wish? What would you like us to do when you get sick? What matters most to you? I think it is in the South Asian culture that, my kids will take care of everything. I'm going to rely on them. And even when they come for the visit, most of the time is the kids they are talking that I see. So that is there, but I things are changing. It's a little more they're active. Um, so I would leave it at that with the mentation wise. And mobility, as I said, is very important. It's interesting that with all the studies that they have done, we see that patients whose gait speed, that walking speed, they can maintain, they have much less a risk of getting very serious medical problems, getting hospitalized, and even they get hospitalized, they can recover better. So if you put all these things together, I think keeping yourself active, functioning, making sure you do, watching television is not stimulation to the memory, to the brain. So I tell, like, read books and do those puzzles, take medications properly. Too many medications, we have a term called polypharmacy. More than 5 medication is polypharmacy. So whatever medication you need to take, you need to know whether you need them or not. Just don't pick up one medication for everything. There is treatment options without medication. So we always encourage that. And I think matters most, as I said, I will discuss a little bit more when we come to the advanced directive.
Yeah, definitely some good points there, especially about the polypharmacy and a lot of drugs that people are taking as people have gotten older, and we've been better able to treat a lot of chronic conditions. Lots of people are coming in on so many different medications. And just the other day I saw a patient who was taking over-the-counter medication for years and years and years, didn't know it was harming him, and he ended up being really sick because of it. And so it's really important to remember that over-the-counter medications are still medications. Tell your doctor you're taking them and how much you're taking. And you guys, then you can make a joint decision about whether that is the best decision for you.
I want to add something in there, because as a physician, when we ask patient, what medicine do you take? In people's mind, prescription medications are medications. Anything over the counter is not medication. So then we ask them that what other medications that you buy from the pharmacy over the counter. I think then sometimes they come up with a bag that they carry or bigger list. Just something we do notice, and this is something I tell everyone, this is like all this sleep aid in the pharmacy, that you have the Tylenol PM and the Advil PM. They have Benadryl in it. This is not a good thing to take for the sleep. I want to add that.
Yeah, thank you for pointing that out. Definitely be mindful of what you're taking, and especially with sleep. I hope my audio is okay. All right, so we're going to move on to the next slide, which, as Dr. Sarkar mentioned, is just a little bit more of a deep dive on mentation and memory. And I wanted to start with this question that she actually brought up to me during our planning call, which was patients coming in and asking her, am I having dementia or what? How do we think about memory change? How do we think about like pathologic memory change versus normal aging and normal memory loss? Yeah, I just love to kind of hear your thoughts, how you think about it, what you talk to your patients about.
I mean, the question I told you is something they always come that, do I have dementia or not? So as I said, everything in the body changes as you're getting older. So brain is changing as you're getting older. Your ability to do things, to learn new things is slower, but you still can do. I mean, I am seeing, people in mid-90s, they're using their cell phone, they're using all their apps very efficiently. So it's not impossible. It can be done. But it is a little slow for them to learn. So what they could do before, they cannot do that quickly. That's what it is. So forgetting a little bit, why did I come to the room? Okay, you leave the room. Oh, now I know why I came to the room. So that is not dementia. Okay, as long as you can do your daily activities, you paying your bills, you're taking your medications, going to the doctor's appointment, whether you drive or not, if you can call a Uber and go to the place or ask your daughter to take to the doctor's appointment, that's still you're independent because you're arranging those things. So when we call it as a dementia, when you are having trouble in doing your daily activities, like these things I was talking about, so then we can say, okay, it's dementia. We do lose some of the memory, not like memory, I will say, but like some verbal memory, then counting. Some of these things we do lose as we get older, but we are able to, how will I say, compensate for it. People do write down what they were supposed to do, what are the questions they're supposed to ask in the doctor's office. This is something I always see bringing the paper out. So they are able to arrange those things. So when they cannot, then we are saying, okay, now you are probably getting into that mild cognitive impairment when you have some deficit, but you can still function, need some support, or you're going into the dementia where you need help from someone to do things. So age-related changes versus dementia, these are two different things. And I think people do get concerned when they're forgetting a little bit, am I having dementia? Then my next question is, who does everything for you? I do them. I take my medicine. I go to the doctor, but I don't remember. I said, okay, this is some memory-related, age-related changes you're noticing. Yes, you can progress to dementia, but it's not dementia yet. So then keep your physical activity on, mental activity on, do read books, do the puzzles. Those are the things. And also, I just want to bring up something is this people do not understand the dementia and Alzheimer's because they ask me, is it dementia or it is Alzheimer's? I just want to bring up dementia is a big umbrella under which Alzheimer is a type of dementia, which is the most common dementia, which is about close to 50% almost. Then we have Lewy body dementia, which probably a lot of us have heard about. Some of the celebrities have reported that they are having it. Then we have frontotemporal dementia, which more of a behavioral problem, is a more of a problem more than the memory thing. And there are other types of dementias. So Alzheimer is a type of dementia, which is the most common dementia. And as you mentioned, that more and more people are living longer. So the prevalence, what we call that number of people having dementia, is much higher as you get older. By the age of 90, 1 out of 2 people will probably have dementia. So that's how common it is. And again, because people are living longer, we are noticing. But if you're functioning and you're doing it, you should be able to maintain your independence much longer. So even in mid 90s, people are doing everything on their own. It's not surprising. I see it almost every day. So it's not that dementia means like 19 you cannot do it. Also, another one I want to bring up, that when anybody hears the word dementia, there is always a scare. The picture that comes to people's mind, that dementia means I cannot do anything. Dementia has multiple stages, like every single medical all the diseases we have. So that is really the end stage. Not everybody goes to that end stage where they cannot walk, they cannot talk, they're in the wheelchair. So some memory loss, yes, they can probably mild cognitive impairment, as I mentioned. Some may need little help, with the showering. Some may need help with putting on their clothes. Some may need help with the cooking and the cleaning. So they are all different stages, and we having more and more medications coming up, newer medications, newer involvement, and a lot of new imaging testing that's we have right nowadays. Obviously, you can talk to your primary doctor about getting those testing done, the MRIs and the CTs that's available for earlier diagnosis. And as I said, there are medications, newer ones coming up. Like last year, there was one, and there is some. So yeah, first talk to the doctor about those things, testing done, and then get to there are a lot of dementia centers who have comprehensive care with the neurologist, dementia specialist, and social workers. They can really plan out the daily activities, even what they can do, what's the next step, and those things. So yes, it is scary to hear the word, but just forgetting where was my key, where was my pocketbook, that's not exactly dementia, as long as you're able to do your daily things.
Think that difference that you mentioned is really important. The ability to kind of do your like activities of daily living, ADLs, versus not being able to do them and having to rely on someone else completely to do all of them is an important distinction to make. And yeah, I think, it is important to remember that nowadays we have a lot of really comprehensive ways to look at and diagnose and treat dementia. And it's if that is a concern, it's definitely something you could bring up at your doctor's appointment or with whoever you're seeing. I wanted to jump into just a little bit of a question break, just because the next half of our webinar we'll be talking a little bit more about how grandparenting is changing and like social considerations, and this was more of the kind of medical piece of it. So I do want to open it up to the audience and ask if anyone had any questions about anything we just talked about. You can also feel free to message them to me or Anushka if you don't want to say them out loud. That's fine too. Okay, I'm not seeing any yet, but I do actually have one question. This is open to both Dr. Sarkar and Monisha, whoever feels comfortable answering it. I wanted to know, are there trends that you see in South Asians in terms of like what age they're going through memory changes, or certain reactions to getting a diagnosis of dementia that you've seen in your work?
I will say that it is when we start discussing about the memory loss, most of the time they say the family is actually saying, oh, they're just older, they're forgetting things. So I think that's when I dig deep into it. And that is my standard question to every single patient I see. Is there any memory concern? Do you forget things sometimes? And then they say yes, and then they say, oh, it's just because they forget. They know everything. They know what they used to do when they were small. So that's when I start digging into more, that, more educating the family, that how cognitive impairment looks, and asking more and making them more aware of it, because it's still a concept that, because yes, you do forget a little bit, as I said, but it's not the dementia. So you need to know what exactly is going on with the patient, not just saying, oh, because you're older, you're forgetting.
And I also feel like, unfortunately, there seems to be a bit more of a stigma in our culture. And I think when someone does get that label of having a diagnosis of dementia, they automatically tend to kind of withdraw. And I think that's where it's really important for the family to know, how do you communicate with someone with dementia, right? I mean, at the end of the day, even as the disease progresses, that person inherently stays the same. So if this person always loved music, by all means, you should take them to a music program, right? If this person loves art, you should still take them. The more you can still intellectually stimulate them, I think that is so important.
Yeah.
And so a lot of what we do also is helping families learn how to communicate with people with dementia, right? I mean, sometimes if they say, oh, she always gets the date wrong, I have to keep correcting her. But in the big scheme of things, who cares if this person thinks that it's Thursday and it's actually Monday, right? The more you tell them, no, you're wrong, you're actually going to make them feel even worse, right? So this is where you have to know how to approach them. And people with dementia can still enjoy things that they used to enjoy 10 years ago, right? So that's why I think it's really important just educating families and helping them understand that the person is still inherently the same, and there's just a different way to approach them.
I think I do agree with you, because this is something we always say to the family, that, when they are making the mistake, do not always try to correct them,
Right.
because then they feel bad about it. And again, they're going to, like you said, go into their shell. So you try to talk something else, and then maybe you want to divert the topic, because that does help.
Yeah.
And always, this is something we see, that they say, oh, when they're with the family, they're fine. When they're alone, they're less interactive. And that's why the socialization is so important, that they're involved, they're doing something throughout the day, there is a plan for the day. It is so important for them to have it.
Mm-hmm.
Because once you have isolation, and this is something we saw during the COVID time, that people who had cognitive impairment, it got declined so fast because of the social isolation. So
Right.
it is so important for them to be involved in the activities and doing things. And, I do teach them every single day, this is what you should be doing.
I thank you for raising your hand, Mancha. I just want to make sure we keep time. Please save your question. We will answer it. We have another Q&A at the end. But I want to make sure we cover all the topics that we have for you today. Next, I wanted to talk a little bit about how grandparenting is changing and how caring for the elderly is changing in this new generation. And I wanted to start with Monisha here. If you could tell us a little bit more about, what is the sandwich generation and what is the significance of it?
Okay. So for those of you who aren't familiar with the term sandwich generation, that basically means individuals who are literally sandwiched between two caregiver roles, one of supporting their aging parents and also financially and emotionally supporting their own family, right? So they are kind of stuck between these two generations. And that's what's by definition the sandwich generation. Now, our culture typically tends to assume that daughters more than sons will assume this caregiving role. And many aging parents often say, oh, this is how it was done in India. But the reality is that caring for people in the US is a lot different than caring for aging parents in India, because in India, first of all, the cost of care is so much cheaper if you were to get live-in help. You have so much extended family. You have neighbors that can help you. In the US, as you know, an average caregiver, depending on where you live in the US, can cost almost $30 to $40 an hour. So it is very expensive over here. And I think that, women in general, especially daughters, we get these subliminal messages and we feel this pressure, which sometimes can be self-inflicted too, right? So I, interestingly enough, have a client right now who they're Indian and they have three daughters. One daughter lives in California, two other daughters live here in Chicago, and the mother has Parkinson's. And between the three daughters, they are trying their best to coordinate the medical appointments, managing her caregiving, trying to keep everything in check, but they are overwhelmed because they themselves have school going kids, they all have full time jobs, they are struggling. And so when I told them, maybe you need to be candid and talk to your dad and express to him that this is a bit overwhelming and maybe you guys can consider getting some help. They did try talking to the father, and then the father's instant response was, but I have three daughters, what is the problem, right? And I think, especially the daughter who lives in California, right? She feels even more of the guilt and more of the pressure because she then feels she needs to be contributing too. So she tries to fly back whenever she can. She tries to coordinate some of the medical care, the appointments, making sure that, the pills are refilled. And I think it is just so overwhelming, right? I think the guilt and the pressure we feel, especially as daughters, can be a lot, and then you've got your own family to worry about. And so this eventually results in like physical strain where you end up feeling exhausted. There is that emotional toll where you feel the stress and the guilt and the burnout. Some people who are working, it's hard for them because it could impact their careers, because they may have to sometimes leave their job,
Yeah.
come back in case there's an emergency. This can create added financial burden. Sometimes there are many things like equipment that may not necessarily be covered by insurance, so you got to cover all that. So I think it's a culmination of all this, and then the self-inflicted pressure that daughters feel in general becomes so overwhelming that I think that when a lot of these Indian sayings are, oh yeah, this is how we do it always in India, it is hard, right? It is hard. And so many times, we always kind of say, okay, what do we need to do to help support them, right? What are some of the strategies we can help you with? I think the most important thing is, of course, delegating, right? If you have other siblings, even if they are your brother, there is no reason why the daughter has to take on everything, right? Share the load with your brother. Try to delegate those tasks. Use community and professional resources, someone like me who can help you and guide you and provide you with those resources that maybe you don't have time to look for. It's important for you to practice self-care and kind of carve out some of your me time. Maybe you also try setting boundaries and even saying, you know what, this is really a lot for me to manage. I need help. It's okay for all of us to ask for help. We shouldn't feel like we have to take it on just because we're the only daughter, right? Sometimes there are support groups. I mean, there's a support group on Facebook called Desi Daughters, right? And that's exactly what it is. It's all the Desi daughters coming together as a tribe, kind of helping each other out, venting, trying to figure out what are some of the resources in California, North Carolina, wherever it is. Sometimes if you're working, you could have like an employee assistance program, and they
Mhm.
sometimes can offer services through your insurance as well. So I think that, it's really important for us to kind of take a deep breath and know that there are options available to us. And just because we're daughters and just because we're female, it does not mean we have to assume that role of being the sole female caregiver.
I mean, I think this is what we also talk when they're talking to us, that they're saying, we do have a social worker in our office. So we always bring her into the room.
Right.
And yes, what you said is exactly what I see every day. So, I have to pick up my grandkid. I have to go to the job. I have to do this. It's a lot on their plate. And then it affects their health because they are kind of missing that part because taking care of everybody. So I always our social worker is a great resource who tells them, what's the next step. even like all these pill pack pharmacies available. So they come pre-packaged, every medication. You don't have to worry about putting them in the pill box. Very simple things. That's such a big relief when we talk to them. These resources are there. I think, yes, getting them that there are resources, there are things to help you. There are stuffs here. Yes, it's not India, but still we do have some stuff. So definitely, I agree with you. Yes.
Yeah, and I mean, like I always some food for thought, right? I mean, I think it would be nice for everyone to kind of think about your life as a pie chart, right? What percent of that pie chart do you devote to yourself? What percent to your spouse? What percent to work? And what percent to your family? And interestingly enough, many women end up having the percentage of me time as the least amount, right? I think all of us get so caught up with our guilt about wanting to be able to spend time with the family, wanting to be able to spend time with the spouse, making sure we get all our stuff done at home, our own job, that we really kind of prioritize ourselves less. And I think sometimes that's almost a disservice, because at the end of the day, if you don't take care of yourself, how are you going to be able to manage taking care of your aging parents, or how are you going to manage taking care of your own kids, right? And so sometimes it's okay for us to be selfish and really focus on looking at that pie chart. And what was interesting to me was, when I did this, I realized my pie chart was pretty messed up. I mean, I had actually devoted like 70% to work, and like 5% to my husband, and like 1% to me, and I think it was such an eye opener for me, because we don't even realize that's what we're doing. And I remember one of my friends, her me time was like 50%. And I was like, oh my God, you're being so selfish. How do you have 50%? And she goes, no, if I don't go for my massage once a week, and that is my time to decompress, then I feel rejuvenated, and I can then focus on my kids and focus on my parents and focus on my career. And it just kind of helps me. And to me, that was like an eye opener, because I was like, you know what? I've been thinking about this all wrong. And I really need to understand that I should not feel so guilty. And it's okay to focus on me sometimes.
Yeah, that's exactly. I mean, yes, this is what we say, that you got to take care of yourself first
Right.
before you're a caregiver.
Mm-hmm.
Yes.
I wanted to also point out one other thing that we didn't get a chance to cover just yet in terms of differences in culture. Monisha kind of got at it when she said, a lot of people have these really big networks in the home country in India, Pakistan, Bangladesh that you can rely on. I also think that's true for, the elderly person, right? Like they might have their friends that they've grown up with, and that they all speak the same language, and they all have the same, shared experiences growing up. But then if they come to the US or they come to another country, all of a sudden, they're isolated, maybe in a suburb house, maybe they don't know how to drive. Their friends are no longer close by. They can't just walk to someone else's house. And I'm saying this, my grandparents lived in India until the end of their lives. And that was one of the reasons they never wanted to leave. And Dr. Sarkar, if you want to talk a little bit more about this, I kind of see you starting to talk.
Yes, I think that's one of the things, because the lifestyle there is different than what is in here. Because there people are more reliant on the public transportation, never walking out and talking to you, saying hi, because that is definitely one of the things that I have seen with my parents when they came here, that, they feel more isolated. They are not having that people, neighbor coming and talking to them. So that's one of the things they always said that they really enjoyed in India. But I just want to bring up that every community in here and every town, they do have senior centers. And I know one of my friends' mom, in here, used to go to the senior center, and she loved to go there because she was able to get transportation from the town. So town had this bus service. So she used to set up with them, and she will go there almost 5 days a week, pretty much spent majority part of the day. And she had people there who were speaking in her language, and she will have a meal there. They will go out on trips. So this is something from the social service office in the town that the person is. They can always look up which are the senior center programs, or the social worker in the doctor's office you can ask for, because I have seen her how she enjoyed, even though she was living alone because her daughter had to go out of the town for a while. She was living alone, but she had a really good life for those, like I would say, for at least 3 to 4 years. She was on her own, but every morning she will get up, she will get on the bus, she will go to the center, spend the day with the people interacting, and come back tired, goes to sleep and gets up next day, because those services are here. Even though, but I think when somebody lives here longer, you can get them into the service, which my parents were not here longer, that I could get them in there. But these services are available, so I would definitely encourage. I saw her how she enjoyed that. That's what I'm saying, that even though you don't speak the exact language in here, but there are like programs, definitely people can go and participate, and these are really good programs.
Speaking of, the different services and the different levels of care, I want to make sure we cover that before our time is up. We kind of already talked about guilt and expectations, especially for women. So thank you for covering that. So we're just gonna move on. But Monisha, I wanted to ask you to give us a little primer on what the different levels of care are. Like, what does independent living mean? And then maybe just a little bit of like a definition about each of them and what it looks like.
Sure, sure. So independent living pretty much is exactly what it says, where someone is independent and they really don't need much help. So most of these are active seniors, and it could be like a retirement community, a 55 and up plus community where people are still living by themselves, are able to drive, are able to cook. If they needed help with housekeeping, they can get it if they want to, but they don't physically need any help. Assisted living is where someone may need some help with either bathing, dressing, toileting, or medication management. And usually in an assisted living, they have a nurse, they have some nurses' aides that can help with showers if needed. So there is some of that supervision. Long-term care is where someone needs that 24-hour skilled nursing. So this could be someone who may physically need a lot of help, either getting in and out of bed, or they could be bedbound. They may have wounds. They may have a lot of nursing needs. Sometimes depending again on your level of dementia, some people could be in a memory unit where again they could still be walking, talking, and still need some of that supervision, mainly from a safety standpoint. Or they could be in a skilled unit because their dementia has progressed and now they need a lot of help, even with things like feeding. So that's where long-term care tends to be like the most expensive, because that's where you need that 24-hour skilled nursing care. Home health care is when someone is at home and is actually considered homebound. What that means is it takes a lot of effort for them to leave their home. There's a recent decline in function. They're not able to walk like they used to. So that's where Medicare will allow for a nurse and a physical therapist and occupational therapist to come to your home for a short amount of time. It could be 4 weeks, it could be 6 weeks. It really depends on your diagnosis. And that's where they see you and get you to becoming at a higher level of function like you used to be. So home health care is only temporary, and it usually is offered when someone gets discharged from the hospital, or they get discharged from a rehab, or if they just had a decline in function, maybe they were falling a lot at home and your doctor felt, you know what, it's difficult for you to get to an outpatient therapy clinic, or maybe you need to have someone monitor a wound that you have, then you get home health.
Okay. Just so people know, in terms of like cost,
Yeah.
for families, like where do
Sure.
these each lie on that spectrum?
So, I mean, again, depending on where you live, right? I mean, obviously, big cities, it's going to cost a lot more. On average, an independent living could cost, $4,000 a month, or it could be something up to $8,000 a month if you're going to a community which has all these different levels of care included, you know. An assisted living, also based on how much help you need. Within an assisted living, also, there are levels of care. So an assisted living can also average between $6,000 to $8,000. And again, every state it's different. So,
Mm-hmm.
don't quote me on these numbers. I'm talking about mainly in Illinois. Long-term care is, of course, the most expensive, and it can go up to $10,000 a month if you're needing a lot of this assistance. And home health care, again, if you have Medicare or Medicaid, it will be covered.
Yeah, but that's for the short term. That's kind of,
Yes,
I think, one
exactly.
of the biggest barrier that I see, that it's not a long-term plan.
Right.
So yeah.
Yeah, exactly. It usually lasts only like 4 to 6 weeks
Yeah,
again,
4 to 6 weeks, it doesn't last
depending on your
that long.
diagnosis.
Mm-hmm.
Right, right, right.
Yeah, the long-term care, most of the time people do end up with the Medicaid. That's kind of, it's so expensive.
Or if
Yes.
you have long-term care insurance,
Yeah, long-term care
it
insurance,
will
if you
be
have, you
covered.
can get that long-term care. Otherwise, majority are the Medicaid patients who are, yes.
Right.
Yeah, thank you for that overview. I hope, this is just like a good way to like, have knowledge of those terms if they come up, so people can actually know maybe what they're asking questions about and get more information about.
Sure.
I want to spend the last couple of minutes today talking about hospice and advanced care planning. And there's like three main topics as I've outlined on this slide. And Dr. Sarkar, I wanted to ask first and foremost, like, what is hospice? What is palliative care? What is the difference, if any, between these two things? Because I think this is a distinction that can be hard to understand if you're hearing it for the first time in like an emergent situation.
Yes, they have a lot of similarity, but there is also a difference between palliative and hospice. So both, similarity is both of them are focusing on the patient's comfort. So any patient is having any symptoms, so they are trying to control the symptom, whether it's a pain, trouble breathing, anxiety, any of those. But what the other difference is, in the when you are palliative care, getting the palliative service, patient is still getting active treatment. Just for an example, someone who has a cancer, who is on palliative care service, they are still getting their chemo, they are still going for any surgery needed, they're going for radiation, whatever is needed. But the palliative team is working with the oncology in their symptom management. And if you go on hospice, if you're on a cancer, the same patient, but the patient is not getting that chemotherapy, radiation, or the surgery. Now the patient is getting only the comfort care, making them comfortable at home. So patient is not going to go to the hospital, is going to stay home and be comfortable at home. So both are focusing on the patient's comfort, but the subtle difference is when you're on hospice, you're not following that aggressive treatment or curative treatment for any whatever disease we are talking about. And I know I mentioned cancer, but it can be anything: heart failure, COPD, lung problem, they all can be. But also, to be hospice eligible for hospice by Medicare and Medicare guideline, you need to have 6 months of life expectancy, and all of them have different criterias that you need to follow. Again, Medicare has those all guidelines. So you need to have less than 6 months of life expectancy, and your physician will say that yes, it's less than 6 months, let's go for the hospice. So that's there. So one of the thing with the hospice, this is because when we are still focusing on the symptom management and comfortable, making the patient comfortable, is the hospice service. This is what I tell my patients, that hospice is still misconception in the community, is that hospice means you stop every treatment that the patient is getting and you just get morphine. That is not true. I'm going to emphasize that that is not true. Yes, you're not getting curative treatment, as I said, but anything that's needed for your comfort, you're still getting it. For an example, a COPD patient using nebulizer, right? So they are getting nebulizer for their breathing, to help with their breathing. They are still continuing the nebulizer. It's not that just we are giving morphine and stopping everything else. Patients on blood pressure medicine still continuing the blood pressure medication if they can tolerate it. So there is that thing when we talk, oh, that means they will stop everything and will just give morphine. That's not true. So that's what hospice is, that you are still keeping them comfortable, but no active treatment. But palliative is they're still seeking active treatment for their underlying disease, which is progressing. And at some point of time, they from palliative they switch to hospice because less than 6 months life expectancy, and there is the curative treatment is not actually benefiting the patient.
Mhm.
So
And I wanted to add also with palliative care, you can still have physical and occupational therapy. So
yep,
that's also a big difference.
you
So
can
just
get all
because,
of them with palliative
exactly.
actually. No,
And in
actually,
fact, people, where pain management is an issue, many times, in rehab facilities, they always recommend you're here for short term rehab, but get that palliative consult to help with the pain management.
just to add, because I work with hospice very closely and even hospice guideline, they can still get a little bit of physical therapy just to get them out of the bed to the chair. If that's their goal, if that's what they want to do, hospice do work with the family to get that physical therapy home to do that. So yes, we are not doing any blood work or any of those things because we are not focusing on those. But whatever is matters to the patient, we do work with the patient and the family on those.
Yeah, I know we're almost at time, but I did want to just give a minute or two to talk about healthcare planning and financial planning. This could be a whole webinar in and of itself, truly. So if you just maybe want to briefly run through those topics,
Yeah.
Dr. Sarkar, just start us off there.
Yes, I think it is very important to, as I said, advanced care planning, healthcare planning. They're all different terms to it. And I encourage, and as I said, when the patient comes to the office and I'm asking, oh, my son is going to take care of it, my daughter is going to take care of it, but it is not that simple. And we need to know what patient's wishes are, and that's what it comes down to. There is a healthcare proxy, which means patient assigns the person who's going to make medical decision. It's only medical. That's what I tell my patients. This is not about money, about finance, what you have in your bank. No, I'm just asking who is going to make medical decision only when you cannot make medical decision. So that person is not going to make any decision as long as we can talk to you. So they understand, they do it. Then there is that's a healthcare proxy. Power of attorney is being done with a lawyer. They do that form. And then there's a POLST form, POLST. I think some of the state, they have it as a MOLST. So POLST is practitioner's life-sustaining treatment order. So this is, every state has this form. Basically, this very clearly states patient's wishes, what matters most to the patient, living independently, doing things, something like this. If the heart stops, whether they want the resuscitation or not, if they cannot swallow, whether they want a feeding tube or not. So those are the things are included in the form. And this form, the patient discusses with the doctor. We don't need any lawyer to do this form. The doctor signs the form and the form is valid. And this form, the doctor signs like every prescription we have to write with our license and our DA thing. So these forms have those also. These are just like an order. And this is valid because it's a physician's order. And this thing, a patient can sit down with the doctor and do the form. And we encourage all the patients to complete it. And how I usually talk to them, and this is something I think we all should think about, when you are doing well, means healthy, stable, this is a time to talk about it. Not when you are sick in the hospital, in ICU, in the ventilator, or your pressure is dropping. I'm starting 3 drips to keep your pressure up. that's not the time to talk about this, because then there is so much stress going on you as well as the family. Everybody's under stress, and that's not a good time. So we should talk about it when you are healthy and doing. And I think Medicare do have this as a wellness visit that yearly a patient gets. This is included in that. That have a conversation. What is your living will? What's your power of healthcare proxy? So doing those, and the post form, I strongly encourage my patients to complete it, because it is a very simple form. You can do, not simple, but with sitting down with your doctor, you can do this form. And DNR, DNI, it is do not resuscitate, do not intubate. So it does, I think the concern that comes on this has to be a physician order. It cannot be just someone saying I'm DNR, DNI. EMS is not going to follow if you just say DNR, DNI without the physician signed order. Post form has that also. So if you can have the post form, you can also get the DNR, DNI in that form included. So DNR, DNI does not mean that you're not getting treated for anything. I think this is where the distinction is. It is only you do not resuscitate when your heart stops, but that doesn't mean that you're going for any chemo. You cannot get that chemo, because it's only valid when your heart stops or your breathing stops. Do not intubate, no ventilator you're looking for. I think it is crucial, and as I said, once a year in the annual wellness for Medicare patient, or annual physical for any patient, just talk to the doctor that, why do I have this? I don't have this. I want to talk about it. I think I encourage everybody to do it. I do to all my patients to talk about this. And financial planning, I think this is important to, maybe Monisha can talk on that how to work on the finances, because the long-term care insurance, like she mentioned, these are important, and how to set those things up. Yeah, I can answer questions at the end. Yeah.
I mean, the reality is that unfortunately, family conflicts sometimes finances are like 40% of those conflicts, right? So that's why it's really important to make sure you establish when you are healthy who is going to be your financial POA, who is going to be your healthcare power of attorney. You want to make sure that you have your will and trust updated, because again, like Dr. Sarkar was saying, don't wait for a crisis to occur and then everyone's scrambling and then making hasty decisions, right? So it's always good to have that proactive planning. If needed, talk to a financial planner. Sometimes there are money managers who can also kind of look at your budget and let you know, okay, this is how much income you have per month. You will be able to afford 4 hours of caregiving a week, because this is what the math looks like. And I think sometimes people don't realize there are so many resources out there that can kind of help create a budget for you. There are financial planners available for you. If you have the means, then yes, there is the option of long-term care insurance, but it is expensive. Their premiums are high. So there are still options out there where if you had the ability to afford it, that could be an option too, because that will help you if ever you needed long-term care, and it can help towards caregiving costs as well at home. So the key message is, be proactive and have a plan before a crisis occurs.
Exactly.
Yeah. All right. Thanks for that overview. I think these are some really important points to remember for, as we care for the elderly. I know we're a teensy bit over time, but I did want to open it up to questions from the audience. I remember someone had a question earlier. Please feel free to unmute and ask your question, or you can drop it in the chat as well.
Hi, I have a question, and then wanted to plug a couple of resources. So first, an introduction. I know some of you, but not everyone. Mansha Mirza, occupational therapist and professor in occupational therapy at the University of Illinois. And the few resources that I wanted to plug are currently we have an ACL funded technical assistance and resource center that focuses on creating resources for AAPI older adults. And we have a few webinars and FAQs related to some of the topics that were discussed here. So we have one on advanced care planning. We also have one on benefits planning, so like applying for Medicaid, Medicare, SNAP, etc. And we're also in the process of creating benefits literacy videos that will be up on our website soon. And then we have one on fall prevention. So I'm just posting the link to our webpage where you can access those resources. Another quick plug is that we are in the process of, we already have a dementia education and caregiver training, and we're in the process of translating it right now into Hindi and then plan to translate it in Urdu as well. And we will be offering the training. It's a 3-session training that we will be offering this summer in the Chicagoland area. My question was unrelated to any of those things. It was actually about medication management. Dr. Sarkar, you talked about polypharmacy and all the challenges with medication management, concerns about side effects, etc. So one thing I've noticed, and by the way, I'm a member of the sandwich generation. So one thing I'm noticing, with my father and aunts and other people in that generation is that they're getting a lot of their health related information from WhatsApp groups. And sometimes what I see on there is kind of dangerous, asking them to get off certain meds to replace them with what people consider as natural or herbal alternatives.
Yes.
And so I, I try to have a conversation with my own father about it. I get a lot of pushback. Often, it doesn't really go anywhere. So just, how do we handle this as healthcare providers as well as caregivers?
I think, yes, it's not new that, they come with a bottle that my friend is taking this. So what do you think? I mean, thank God they're asking it, that should I take it or not? No, this is not for you. I mean, this one has just these vitamins, but you're already taking it. So what's the point of taking it? So this is what, and they said, oh, exactly, this is what it is. My friend is taking it. Can I take it? And someone has stopped taking it. And why do I have to take it? Because that person have stopped taking it. So it is so much. And then I think we sit down, and it does take a little time, that what works for somebody may not work for you, because you're two different people. You may have high blood pressure, that person may have high blood pressure, but your body system is not the same like that person's body system. So let's sit down and talk why you want to take it. What's the purpose for you taking it? And you probably have seen, like you said, people do always give those advice. I am taking it, you should be taking it, when they sit down and chat. But that's when I said that's not the way to sit down and talk. You talk about other things, other activities, but not about the medication. For any medication you need, first look what the medication contains, and then go to your doctor and talk to the doctor. And that's what I said. It's over the counter does not mean it is not a medication. It's still a medication. It has, people, honestly, we have to read all about this over the counter ginkgo biloba. People is taking this CoQ10. People takes like vitamin E mega doses. So, people are taking all this. It's a $1 billion pharmacy. I mean, the business that's going on, but it's not right. I mean, why do you need, I can give you an example. Somebody brought 3 bottles. All 3 bottles have some different combination of vitamin A, vitamin C, pyridoxine, these things. I said, why? Just see all these things. But my friend is taking it. I said, that's the reason you should not take it. I think what you said about that, let's sit down and talk. Why do you want to take it? And why that person is taking it, let's talk about that also. But does that apply to you? Because you're not the same person. I think this is how I sit down and talk to them. Honestly, majority of them do understand, but I would say that when that comes up, maybe you want to ask them to have a conversation with their primary provider, PCP. Why don't you go and talk to your PCP? see if you need this one, because medications should not be the next door neighbor telling you what to take. Yes. It is, unfortunately, it's people do come and ask that question. And none of the over-the-counter medication, again, they are still medication. As I mentioned, the Tylenol PM and Advil PM, this is something we face very frequently because sleeping is a problem as you get older. And I am taking it. After taking it for some time, and then we said, talk why you should not take it. Yeah. Does that answer your question?
Yes, it does. Thank you.
Yeah. You're welcome.
We have any more questions from the audience? Yeah, I don't see any more questions. And I think, we did a really good, I know we're over time, so I want to be mindful of that. I think, thank you both for doing such a good overview of this really important, complex topic. There are so many considerations, social, economic, medical, that go into caring for our elderly and providing them with, good care at the end of their lives. And I'm glad we were able to give a primer on some of those topics at the end, about like the different types of care and, what end of life planning might look like. Just so people know about those things, and next time they hear them or next time they go see their PCP, maybe they can bring them up and talk to them. That is all I had for everyone today. Thank you, audience members, for joining us. We really appreciate your attendance and participation. This is the last part of our Women's Health series, so thank you if you've been to any of the other Women's Health webinars for joining us there. We're really glad to be able to bring this resource to our community. Like I think Shobana put in the chat, all of these are recorded and they will be put on YouTube. So if you want to reference them later, or you want to share them with anyone in your community, please feel free to do so. And yeah, thank you, everyone.